Hello, my geniuses. Welcome to another pharmacological lecture series. Today, it's your green science tutor Lorenzo, and we'll be talking about the pharmacology of the skeletal muscle relaxant. So, we want to know about the drugs that act on the skeletal muscle to make them relax or to prevent what contraction. So, if you have not watched my previous video, I have different playlists on every systems in the body. Their specific pharmacology, so you can watch them and understand the drugs and know how to prescribe their mode of action, their duration, their pharmacokinetics, and everything. So you will enjoy all the videos, and always make sure to subscribe to my video always, and make sure you turn on your post notification button so that anytime I drop any video you'll be sure to be notified. And make sure that if you want me to make a video for you, just write it down in the comment section. When I am done, when I look at it, I will surely make that video for you. So let us jump right into the video. Welcome to another lecture series today on pharmacology. I'll be treating the skeletal muscle relaxant. Now this is under the group of drugs that is acting on the peripheral nervous system, because our last one under the group we talked about the drugs acting on the autonomic nervous system. So we have finished that already, so go watch that playlist. But this one is drugs that is acting on the peripheral nervous system, and we'll be treating the skeletal muscle relaxant. Now in the skeletal muscle relaxant we have to introduce it, so let me just explain to you what the skeletal muscle relaxant is. They are a group of drugs. Now listen to me. They are a group of drugs that act on the what neuromuscular what junction. They are a group of drugs that act on the neuromuscular junction or within the central nervous system in order to what reduce what muscle tones, cause what paralysis, or relieve what spasms. So they can either act on the neuromuscular junction peripherally, or they are act centrally in the central nervous system in order to reduce what muscle tone, because if there's hypertonicity the muscles will be very stiff. So what the skeletal muscle relaxer helps you to do is to reduce the tone and paralysis, and what also release contraction caused the what stiffness or spasms. Now among them you have the word neuromuscular blockers, so we'll still classify them later, but always know that there's what we call neuromuscular blocker. Now these are specific drugs that is used to what relieve what temporal paralysis of skeletal muscle. They release what temporal paralysis of skeletal muscle, particularly doing what surgical procedure. So they do use it during surgical procedure, and also endotracheal tube intubation. So when they want to intubate a patient, they also use neuromuscular word blockers, and also they use it during mechanical word ventilation. So when they are placing patients on the mechanical ventilation, or when they intubate the patient, or when the patient is having temporal paralysis during what general surgery, they can use what neuromuscular word blockers. But unlike the CNS muscle relaxant, the neuromuscular blocker do not cause sedation or what anesthesia. They act peripherally on the neuromuscular what junction to interrupt what transmission between the motor nerve and the what skeletal muscle. So neuromuscular junction between the motor neuron and the what muscle cell. So there's an interruption there, because when acetylcholine is released, or when any neurotransmitter is released and it binds to the receptor on the muscle, what happens? It produces contraction. So what do you want to do? You want to block that transmission. That is it. That is neuromuscular what blockers. But for CNS stimulant, their own is they cause what sedation and what anesthesia. So that is very important. Especially they use it in general surgery, they use it in endotracheal intubation, and they use it in mechanical what ventilation. That is for the neuromuscular blockers. But the CNS is primarily used basically for what sedation, anesthesia, and I'll talk about so many things. So just stick to the video. Now we'll be going under the classification of what skeletal muscle what relaxant. So very easy. You have to just stay throughout the course of the video, because I'll be classifying it for you. Now we have the one that is acting on the CNS, which you call the central acting muscle relaxant, and we have the peripheral acting muscle relaxant. Very easy. Now like I said, the central acting muscle relaxant, they are acting on the brain and the spinal cord in order to reduce what spasms and muscle tone. Don't forget, the central acting muscle relaxant, they bind to the brain. They have a receptor in the brain and the spinal cord. Their goal is to reduce spasms and what muscle tone. But the peripheral acting, what happened? They act directly at the what neuromuscular what junction. They act there. They act at the neuromuscular what junction, acting as a blocker. So they block the neuromuscular transmission, or they can act within the what skeletal muscle fiber. Don't forget. And their primary purpose is to what produce what muscle relaxation, paralysis without altering consciousness. So they don't want to alter consciousness, they just want to produce muscle relaxation. So for a muscle that is very stiff and spastic, so you use muscle relaxant to reduce it, maybe the patient is having any neuromuscular issue, or the patient is having any brain damage that damage the motor areas in the brain, so there might be spasticity. And if there's spasticity, the muscle tones will be very very strong, and from there you can give them the muscle relaxant in order to what, reduce it. So we'll be dissecting this group one after the other. You get it now? We're dissecting them one after the other. So the first time we'll start with the neuromuscular what, blockers. The neuromuscular blockers. Now in the neuromuscular blockers, we'll be taking them one at a time. They are divided into two. You get it now? They are divided into two. So the first one we have is the direct acting agent. What is the direct acting agent? They act directly on the skeletal muscle fiber. Again, we have the direct acting agent and we have the neuromuscular what, blocking agent. So two agents. You have the direct acting agent and you have the neuromuscular blocking agent. So under the direct acting agent, you have what we call dantrolene sodium. So we have dantrolene sodium, and this dantrolene sodium, what does it do? It inhibits what, calcium release from the sarcoplasmic what, reticulum, because normal during neuromuscular transmission, what happens when there is increase in what, end play potential, or when there is a surge or amount of sodium entering into the what, post synaptic membrane, like it's the muscle cell. When there's surge amount, so it brings out calcium. So calcium flows through the T tube from the sarcoplasmic reticulum, so it flows outside into what, the sarcoplasm. So it's coming from the sarcoplasmic reticulum to the T tube to the sarcoplasm. So there's a release of calcium, don't forget. So during contraction in the postsynaptic membrane called the muscle, what happened? Calcium is released from the sarcoplasmic reticulum into the sarcoplasm. So what does dantrolene do? Dantrolene what, inhibits it. Dantrolene what, inhibits it. So one thing you need to know, that dantrolene is used for what, malignant what, hyperthermia. We'll be discussing it later. It's used for malignant hyperthermia and what, spasticity. So we'll discuss it later. It's very very what, important. Under the neuromuscular blocker, so we will not divide it into what, depolarizing neuromuscular blocker and non-depolarizing neuromuscular blocker. So very very important. So we have depolarizing neuromuscular blocker and non-depolarizing neuromuscular blocker. So under the depolarizing neuromuscular blocker, I will explain what it means. The example is what, succinylcholine. So when you remember succinylcholine, or you can call it succinylmitonium, so SS, succinylcholine or succinylmitonium, don't forget succinylcholine. Remember the first one we talk about, so you remember acetylcholine, succinylcholine, acetyl from acetyl-CoA, but this one is succinyl-CoA, so we have succinylcholine. So succinylcholine, or you can call it succinylmitonium. So that is number one group you can see under the what, depolarizing neuromuscular blockers, and you can also see decamitonium too. So but this one is normal, is not in use. So you have succinylcholine, or you call it succinylmitonium, and you have decamitonium. So this is the example under the word depolarizing neuromuscular blocker. Now under the non-depolarizing neuromuscular blocker, we can call it competitive blocker. They are divided based on their duration of what, action. They are divided based on their duration of action. We have the one that acts for a long time, which is the long acting agent. We have the intermediate acting agent, and we have the short acting agent. So don't forget. So the non-depolarizing neuromuscular blocker is divided based on their duration of action. So you know the agents that works very faster and very efficient based on their duration of action. So you have the one that acts for a long time, you have the act for a medium time, you have the one that acts for a short time. So I'll be giving you them one after the other. So very very simple. So when you remember TPDP, like in Nigeria now, we have what we call PDP party. So we have PDP. Are you getting me now? PDP, TPDP. So when you remember TPDP, you need this agent, they work for a long time. TPDP, they work for a long time. So who fall under the long acting agent? T is a tubocarines. So when you remember tubocarines, you remember the first one. So tubocarines, I don't think they are in use, but we'll be discussing them one after the other. You also have what? Pancuronium. So pancuronium is there. So TPDP. TPDP. Pancuronium is there. After pancuronium, you have doxycuronium too. You have tubocarines, you have what? Pancuronium, you have what? Doxycuronium, and you have what? Pipercuronium. So you have what? Tubocarines, or you have gamma tubocarines, you have what? Pancuronium, you have what? Doxycuronium, and you have what? Pipercuronium. So when you remember this one, TPDP, you remember the long acting what? Agent. But the one that is useful here majorly can be pancuronium, but we'll be discussing it as we go. Don't forget. So also alpha tubocarines and what, your decamitonium, they are not clinically in use. They are not clinically in use. But all I want to do is I have to just tell you everything. So in case for your exam, they might just bring anyone, so you should know. So under the TPDP, so when you remember only TPDP, you remember the pancuronium, doxycuronium, and pipercuronium. These are under the long acting agent. So you should also know that tubocarine acts for a long time. Why it's not more in use? Because it produces so many side effects. So under intermediate acting, don't forget under intermediate acting. So you remember what we call very rough car as a mnemonic. So if you want to remember the intermediate acting, remember very rough car, very rough car. So one thing you have to remember, that if you are reading what is very in this case, very rough car. So this car is very rough. The first one is PDP, which I say is a political party in Nigeria. The second one is very rough car. So what is the very here? The very is what? Vecuronium. Vecuronium is a very rough car. So don't forget, very rough car. Vecuronium. What is rough there? The rough there is what? Rapacuronium. Rapacuronium. So you have Vecuronium, you have Rapacuronium. Then what is the C there? Very rough car. What is the C here? Cis Atracurium. Cis Atracurium. So very Vecuronium. R, which is rough, is what? Rapacuronium. You have C, Cis Atracurium. So now what is the car? CAR. What is A there? You have Atracurium. So if you remember Cis Atracurium, you have Atracurium. And the last one you have Rocuronium. Don't forget. You have what? Rocuronium. But Rapacuronium, I don't think also whether it's in use. But I'll be telling you the ones that are in use and the ones that are not in use, so you know. So under the first one is PDP. You have Pancuronium, you have Doxacuronium, you have Pipecuronium, and also Turbocarins that is not in use. Under the intermediate that in use, very rough car. Vecuronium, you have what? Rapacuronium, you have what? Cisatracuronium, you have Rocuronium, and you have what? You have Cisatracuronium, you have Atracuronium, and you have Rocuronium. So don't forget. The last one under the short acting agent is just Mevacurium. So Mevacurium. So don't forget Mevacurium. So how we differentiate them under long, intermediate, and short? Always know that. Look at the short. The short has a what? The suffixes. Look at the suffix. Rurium, curium. Look at the suffix. Curium. Others have rhonium. Why the short acting agent have what? Curium. So with that, you know that is the shortest acting agent. Yeah, don't forget. Now the next thing we talk about their mechanism of action. We talk about their mechanism of action. Don't forget. So they all have the same mechanism of action, since we'll be talking about them together. So always remember now, the neuromuscular blockers under the depolarizing acting agent. The depolarizing, what is the mechanism of action of the depolarizing agent? So what is the depolarizing agent in this case? It is what? Succinylcholine. So we have succinylcholine. I remember when you remember acetylcholine, you remember succinylcholine. So take it one step at a time. So what is the mechanism of action of succinylcholine under the depolarizing neuromuscular blocker? So Nisinam, they mimic what? Acetylcholine. So succinylcholine mimic what? Acetylcholine, and cause what? Persistent depolarization of the end plate potential. So what happens? So they increase the availability of succinylcholine on the receptor. So succinylcholine, acetylcholine, the same thing. So it mimics acetylcholine and it causes persistent depolarization. So it continues binding to the receptor. When it continues binding to the nicotinic receptor, what happens? It allows the opening of the ion gated channel for the inflow of sodium. So sodium is influxing inside. It's influxing inside. So the end plate potential continue to depolarize, causing what? Vesiculation. So when it causes vesiculation due to an increase in depolarization of end plate potential, and what this causes? Vesiculation. So when it causes vesiculation, so excess amount of depolarization, so the cells becomes too depolarized and become too excited. So what happens? It causes flaccid paralysis. Don't forget, like I said, it mimics acetylcholine. So succinylcholine mimics acetylcholine, and when it mimics acetylcholine, it binds to the receptor and causes persistent depolarization of the end plate. This causes vesiculation, and excess vesiculation causes what? Flaccid what? Paralysis. But one thing you have to know, it takes two phases. The phase 1 causes what? Depolarization block. Are you getting that? The phase 1 causes depolarization block, while phase 2 causes desensitization of the block. Don't forget. So the first one causes depolarization block, while the second one causes desensitization of the block, which resembles what? Non-depolarizing agent. So now what happens? So when there's consistent depolarization, at some point what happens? It stops. It stops and it blocks it and it inhibits it. Why? Because the cell is what? Excessively what? Depolarized. Don't forget. So that's how the direct acting agent is. They mimic acetylcholine and allows continuous what? Depolarization. The first one is, first of all, it causes depolarization block, while the second one is what? Causes desensitization block. The next one is a non-depolarizing neuromuscular blocker. So we have talked about the depolarizing neuromuscular blocker. The non-depolarizing neuromuscular blocker, this one, they compete with what? Acetylcholine binding to the nicotinic receptor. So naturally, acetylcholine is released. And when they are released, what do? They bind to the nicotinic receptor. But now instead of them to bind to the nicotinic receptor, the competitive neuromuscular blocker say no. They bind to that receptor and prevent the what? Binding of acetylcholine. And this causes what? non-depolarization. Instead, it causes hyperpolarization. Do you get it now? So I will go again. Instead of them acetylcholine to bind to the receptor, they say no. They bind to the receptor themselves, and when they bind to the receptor, they prevent acetylcholine from binding. Do you get it now? So now, since they are preventing acetylcholine from binding, so no depolarization, and since no depolarization and no action of acetylcholine on the receptor, which means no contraction. So if no contraction, what's happening? Paralysis. Are you getting me now? But the depolarizing neuromuscular blocker, which is succinylcholine, this one, they bind to the receptor, but they bind continuously. So their continuous depolarization later causes what? Flaccid paralysis. So it's still the same paralysis, but that one is caused by continuous depolarization, but this one caused by blocking of the nicotinic receptor. This one do not like depolarization. Instead, it causes what? Relaxation. Do you get it now? But it can be reversed by what? Cholesterase what? Inhibitor. So it can be reversed by then, which is the indirect what? Cholinergic agonist. So it can be reversed by then. So when you give the patient endorphinium or neostigmine, it could reverse it. You get it now? So one thing we have known, we have talked about the depolarizing and we have talked about the non-depolarizing. Do you get it now? Hope it's making sense to you now. So go back, listen to it over and over again. It will help you because it is very, very important. So also remember the classification I gave you at the beginning. So now, what is the pharmacokinetics now? Let's take a chill pill for a while. What is the pharmacokinetic? Now, always remember that most neuromuscular blockers are given IV. So they are given IV, not what? Oral. Because when they are given oral, their bioavailability is low. Their bioavailability is low, so they are not giving what? Oral. They are giving what? IV. One. So always know that the neuromuscular blockers are giving what? IV. Now, succinylcholine has a rapid what? Onset. Don't forget. Succinylcholine has a rapid onset of about 30 to 60 seconds. So if you give succinylcholine, it will start its action very, very well. But one problem now, it has a shorter duration of action. A shorter duration of action lasts for what? 5 to 10 minutes. So if you give succinylcholine, it dies out very faster, but it starts fast. So something that starts fast can end faster, just like the saying. So if you get something fast, you have to wait for it, because if you start fast, you might end fast. You get it now? Why? Because it is hydrolyzed by what? Plasma what? Pseudo or cholesterol. So it's hydrolyzed faster, it is broken down faster. That's why it has a short duration of what? Action. Don't forget. Now, Atracurium is degraded by what we call Hoffman what? Elimination. That's what we call Hoffman elimination. So the Hoffman elimination degrade what? Atracurium. So Atracurium is under the what? Intermediate what? Duration of action. Don't forget. Pancuronium and Vecuronium, they can be what? Metabolized. So the liver will metabolize them, and when the liver metabolize them, they'll be excreted through the what? Kidney. Dantrolene can either be taken oral or IV. So you can give Dantrolene oral and IV, because the high dosage can also increase its bioavailability. So don't forget. Just for your exam, so I'm just giving you all the specifics just because of your exam. There's a lot of things to talk about. So we might also take all these drugs one after the other. We'll take them one after the other, so you know specifically for your exams. But now the Dantrolene can be metabolized by the liver very, very fast. Don't forget. Get it now? So one thing also you have to know now in the center acting agent now. So moving on to the center acting agent. So we'll talk about both of them differently. So moving on to the center acting agent. Now what do they do very well now? Now the center acting agent can be divided based on different stuff. You get it now? We'll be picking the ones that are very, very important. We're picking the ones that are very, very important. Not all of them are what? Important. The center acting agent, what happened? They bind to the receptor in the brain and what? Spinal cord, which I've said before. So the first one we'll be picking out is what we call Gaba what? Mimetics. So what's Gaba mimetics? These drugs what? They mimic Gaba itself. And what is Gaba used for? Gaba is used for what? Causing what? Hyperpolarization, causing relaxation. So the Gaba mimetics number one is Baclofen. So Baclofen is a Gaba mimetics, an important Gaba mimetics. So the next one is what? Benzodiazepam. So benzodiazepam is another important agent. So when we are picking benzodiazepam, there's only one drug that comes into that class is diazepam, because diazepam has a longer duration of action and is much more important than all of them. So the next one is what? Center acting what? Alpha agonist. So if you go to our andronergic video, our andronergic agonist video, you see what? Tizanidine. So tizanidine is a what? A central what? Alpha 2 what? Agonist. Don't forget our alpha 2 what? Agonist. So if you go there, you watch the video and you know how alpha 2 agonist. So because we'll also talk about it. And the last one is what? Cyclobenzaprine. So when you remember cyclobenzaprine, you remember that it's also part of the what? CNS what? Acting agent. Also, there are also many classes. So there's cosiprodol. Cosiprodol is there, and other classification. Mitocarbamol. mitocarbanol, cociprodol. They are under also, there are plenty of drugs that is under this classification, but like I said, I'll be giving you the one that is what useful, the one that they use now, the ones that you see for your exams. You get it now. So now under the baclofen, so what does baclofen do? Like I said, it's a GABA mimetic. So it binds to GABA B receptor, because we have two receptors. We have the what GABA A receptor and we have the GABA B receptor. Don't forget. We have the GABA A receptor and we have the GABA B receptor. So benzodiazepine bind to the GABA A receptor, and when they bind the GABA A receptor, they are allowing the influx of what chlorine. So chlorine will be entering inside the cell. And remember, when there's negativity entering the cell, what happens? It causes what hyperpolarization, which causes relaxation. But when positive enters into the cell, it causes excitation. Don't forget. So positive excitation, negative relaxation. So when diazepam bind to GABA A receptor, which is a drug under benzodiazepine, when they bind to the GABA A receptor, what happens? They allow the influx of what? Chlorine. When they allow the influx of chlorine, what happens? It causes what? Synaptic what? Inhibition. Baclofen binds to GABA B receptor. So why diazepam bind to GABA A receptor? If baclofen binds to GABA B receptor, what happens is allowing the influx of what? Potassium. Don't forget, GABA A receptor allows diazepam to bind, allowing chlorine to enter. Baclofen binds to GABA B receptor, allowing potassium to enter. So when potassium enters, what happens? It causes what? Hyperpolarization of spinal interneurons. Very important. Hyperpolarization of spinal interneurons. It reduces what? Excitatory what? Neurotransmitters, thereby decreasing what? Muscle spasticity. So very, very important. Very, very important. So if you with baclofen, what happens? You are decreasing muscle spasticity by hyperpolarizing what? Spinal what? Interneuron. So the ion entering here is what? Potassium, while chlorine is entering through the what? GABA A receptor. So don't forget. The next one is the central alpha agonist. So who is the central alpha agonist? We have what we call this tizanidine. So when you remember tizanidine, you remember what? They are counteracting what? Alpha A what? Receptor. But unlike the ones we talk about in the androgenic agonists, it's not all of them that have central acting agent. But this one falls into that group. So when you go to my video, you watch it. This one, they reduce what? Presynaptic what? Excitatory neurotransmitter to be released. So they are preventing what? A new epi to be released in the brain. Because when the new epi bind to the alpha 2 receptor, what happens? It increases what? Synaptic what? Excitation. So you do not want synaptic excitation. You do not want an increase in sodium entering. You do not want excitation. You want inhibition. You want relaxation. So we are reducing neuroepi in the brain. So when we reduce neuroepi in the brain, we cause what? Relaxation. That's the alpha 2 agonist, because neuroepi binds to alpha receptors while epinephrine binds to beta receptors. Don't forget. Now, the last one is what? Cyclobenzaprine. So what does cyclobenzaprine do? They act on the brainstem to reduce what? Tonic motor activity. You have the GABA mimetics, you have the benzodiazepam, you have the central acting alpha 2 receptor agonist, and you have the what? Cyclobenzaprine. Are you getting that? I can also say you also have carisoprodol and you have mitocarbanol. They are under the mephenisen congeners. So do you know what the mephenisen congeners are? They are the first drugs that are found to cause what? Muscle relaxant in animals without producing what? Unconsciousness. So the first drug that was found to produce what? Muscle relaxation is what? Mephenisen congeners. So under the mephenisen congeners, you have the carisoprodol, you have the mitocarbanol, you have a lot of drugs there. But the only ones we'll be focusing on is benzodiazepam, Gaba mimetics, and central alpha 2 agonists, so which you have seen, and also cyclobenzaprine. So these are the only drugs that are being what? In use currently now.